If your gums bleed every time you floss, don't panic. That single thread of blood is important information, not a verdict. In the next few minutes, I'll give you a clear, practical triage, 3 quick home checks you can do in a few minutes, a focused 48-hour trial you can start tonight, and what changes you should expect, plus how to tell whether this is likely a fixable technique problem or a sign of something that needs professional care. Before we begin, if you want a visual guide to proper interdental cleaning, watch the flossing technique demo linked next. It will make the home steps that follow much easier to put into practice. Start by grounding the problem. You're brushing, you floss, and you see blood on the thread. Maybe it happens only in one spot, maybe it happens along the entire arch. Maybe you've noticed bad breath, tender gums, or a loose tooth. These are all signals that point in different directions. Bleeding with interdental cleaning is common. It can mean something as simple as inflamed gums from inconsistent cleaning, or as significant as periodontal disease. Your job over the next 2 days is to collect useful clues, gently, safely, so you and your clinician can decide what to do next. Here are 3 quick checks you can do now. Each one takes less than 2 minutes. First, a visual inspection. Stand in front of a mirror with good light. Pull your lip up and look closely at the gum line where the teeth meet the gum. Healthy gums are generally a firm, pale pink and follow a scalloped line around each tooth. Inflamed gums often look swollen or bright red and may bulge slightly between teeth. Receding gums show longer-looking teeth or exposed root surfaces. Look for white or yellow pus near the gum margin, which is less common but important to note. Gently try to see if any teeth feel unusually long, loose, or shifted. If you see swelling, dark red tissue, pus, or marked tooth mobility, those are stronger signals that a dental evaluation is needed sooner rather than later. Second, the floss gauze check. Take a piece of floss or a clean strip of gauze and, as you normally would, clean between 2 adjacent teeth that you suspect bleed. Observe where the blood appears on the thread. Is it a single point of contact, or is red smeared along a long segment? Does the blood appear as a thin streak or as heavier droplets? Blood limited to 1 or 2 areas often points to a localized problem: a torn gum papilla, food trapped near a restoration, or an overly aggressive floss move at that site. Blood smeared along many interdental contacts suggests more generalized inflammation, which is more consistent with gingivitis or periodontal involvement. Note any unusual odor on the floss, but don't rely on smell alone to diagnose. Trapped debris can have an odor, but smell is not a definitive test for periodontal disease. Third, pattern in context.
Ask yourself a few simple questions and be truthful. Does bleeding happen only when you floss, or does it happen spontaneously between brushings? Has it been happening for days, weeks, or months? Are there extra risk factors? Do you smoke, use smokeless tobacco, have diabetes, take blood thinners, use certain supplements like high-dose fish oil, or recently start a new medication? Do you have chronic sinus or throat problems, such as postnasal drip or recurrent tonsil debris? These contextual details change the likelihood of different causes. For example, someone on anticoagulant therapy may have more noticeable bleeding from minor trauma, while someone with uncontrolled diabetes is at higher risk of periodontal infection that bleeds readily. A quick patient vignette can make this concrete. Anna is in her 30s and called because every time she flosses at night, she sees a small streak of blood near her lower left molar. She brushes twice a day, but admits she often skips flossing for several days in a row. Her mirror check shows slight redness at the papilla between the 2 molars, and the blood appears only at that one contact. She takes an oral contraceptive and an occasional NSAID for headaches. Because Anna's bleeding is focal and she has intermittent flossing, the most likely explanation is localized inflammation from inconsistent cleaning, and possibly a trapped food particle or rough restoration edge. That's a scenario where a short, conservative trial of improved technique and careful cleaning frequently leads to rapid improvement. Contrast that with Marcus in his 50s, who reports bleeding on floss along most of his teeth for weeks. He also reports bad breath that hasn't responded to breath mints, and he feels his lower front teeth shift slightly when he runs his tongue over them. His mirror check shows generalized redness and mild recession in several areas. Marcus has type 2 diabetes and has been under more stress lately. His pattern suggests something deeper than a one-off technique problem and raises the possibility of periodontal disease, the kind that needs professional probing and radiographs to fully evaluate. With those quick checks in hand, you're ready for a short conservative diagnostic trial, a 48-hour focused routine designed to reduce trauma, remove plaque, and give you an early signal about whether bleeding is technique-related or disease-related. This is not treatment for advanced periodontal disease. It's a safe, evidence-framed way to gather information and potentially reduce reversible inflammation. Begin tonight. For the next 48 hours, follow a consistent, gentle routine morning and evening and after major meals if you can. Be gentle but thorough when you clean between teeth. Aim for a method that contacts the side of each tooth without snapping the floss harshly through the papilla.
The commonly described C shape, where the floss is cupped slightly around the tooth surface rather than pulled straight down like a saw, helps reduce papillary trauma and removes plaque effectively. If you have wider spaces between teeth, an appropriately sized interdental brush may be more comfortable and effective. Choose one small enough to fit without forcing and use it gently. If you use floss picks, be mindful that some designs encourage a sawing motion. Try to seat the floss along the tooth surface and move it with finesse rather than force. Rinse with warm salt water once or twice daily. After brushing or after a meal can be a convenient time. A simple saline rinse soothes inflamed tissue and helps dislodge loose debris. This is a short-term comfort measure. It doesn't replace mechanical cleaning and is not a long-term antiseptic strategy without a clinician's recommendation. Hydration matters. Dry mouths are more prone to plaque accumulation and irritation. If you notice your mouth is dry, increase water intake throughout the day, and consider sugar-free xylitol gum after meals to stimulate saliva. Xylitol also reduces bacterial activity in the short term. Avoid alcohol-based mouthwashes for now. If you choose an antiseptic rinse, use an alcohol-free formula and limit short-term use. Prolonged antiseptic rinsing can alter taste and oral flora, and products with proven side effects should be used under clinician guidance. Document what you see. Keep a simple log, twice daily entries noting a bleeding score from 0, no blood, to 10, heavy oozing that's hard to control, which teeth or quadrants bleed, and any additional symptoms such as pain, swelling, looseness, or systemic signs like fever. Even a short checklist on a phone note will do. This documentation is valuable if you need to see a clinician, and it helps you objectively track whether the problem is improving. Avoid aggressive maneuvers. Don't probe deep into pockets with toothpicks, metal objects, or pointed instruments. Do not attempt to scrape around the gums with sharp instruments, and do not try to dig out anything stuck near the tonsils or back of the throat yourself. These actions can open wounds, introduce bacteria, and increase bleeding. If you use an interdental tool, use it gently and only as indicated. Expectations over the first 48 hours are realistic, not miraculous. If bleeding is due to trauma from infrequent or aggressive flossing, or from superficial gingivitis caused by plaque buildup, you will commonly see a meaningful reduction in bleeding within 48 hours to a few days of consistent, gentle cleaning and rinsing. The tissue begins to calm down quickly when plaque is removed regularly and mechanical irritation is minimized.
On the other hand, if bleeding is due to established periodontal pockets, untreated restorative issues, or systemic factors, the bleeding may persist at similar levels or even feel worse as you begin to dislodge deeper debris. That's an important signal that home measures alone are not sufficient, and a professional evaluation is warranted. A vignette to illustrate the 48-hour path. Leah, a teacher in her 40s, noticed generalized bleeding when she flossed after a long holiday. She started the 48-hour trial, gentle flossing twice a day with careful attention to technique, a saline rinse at night, and sugar-free xylitol gum after lunch. She kept a simple log. First night bleeding score 6 at several sites. Morning of day 2, score 4 with less redness. By the third evening, the scores were consistently 1 to 2, and the tissue looked pinker. Leah's pattern suggested gingivitis from inconsistent care, exacerbated by holiday snacking, a reversible issue with improved hygiene and a routine professional cleaning soon after. She scheduled her next dental cleaning, but she didn't need urgent periodontal therapy. Now, the important part, how to interpret what happens at the end of the 48-hour window. If bleeding is reduced substantially within 48 hours, perhaps by half or more, or down to an occasional light bleed, that strongly suggests the primary driver was superficial inflammation from plaque and technique. The sensible course is to continue the gentle interdental routine, maintain consistent twice-a-day mechanical cleaning, replace or refresh interdental tools as needed, and schedule a routine dental cleaning if you are due. Improvement in days is typical for gingivitis. If you maintain the new routine, you should see continued gains over the following weeks. If bleeding shows little change after 48 hours, or if it increases, then the likelihood that something more than simple gingivitis is present becomes higher. Persistent bleeding despite careful technique could indicate periodontal pockets, harboring bacterial biofilm below the gum margin, restorative issues like overhanging margins or poorly fitting crowns, or contributing systemic factors. In that case, a targeted professional assessment is the appropriate next step. Your dentist will typically perform a periodontal probe exam to measure pocket depths, evaluate for attachment loss or recession, and may take bitwing or periapical radiographs to look for bone loss. Those findings, not smell on a piece of floss or self-reported bleeding alone, guide decisions about scaling, root planing, or referrals to a periodontist. There are a few nuance points to consider while you're doing the trial. First, Localized bleeding that persists at one or two teeth often points to a local irritant, a food trap, calculus, tartar, that can't be removed by flossing, or a rough edge on a filling.
People often find that one troublesome contact is the source of repeated problems. That single contact may need a clinician's adjustment. Second, multiple sites bleeding with evidence of recession, tooth mobility, or radiographic bone loss indicate a need for formal periodontal therapy. Third, systemic conditions and certain medications can amplify bleeding. If you're on blood thinners, immunosuppressants, or have uncontrolled diabetes, these factors alter how aggressively your gums respond and how quickly they heal. It's also important to keep ENT and throat issues in mind. Sometimes people attribute bad breath or an unpleasant taste to gum problems when the source is oropharyngeal. Tonsil crypt debris or postnasal drip can mimic halitosis and even lead to a perception of bleeding in the back of the mouth. If you notice that the back of the throat is involved, persistent sore throat, visible white or yellow debris on the tonsils, chronic postnasal drainage, an ENT evaluation can be useful. That said, bleeding when flossing is rarely caused by tonsil disease. More often, the bleeding originates from the gingiva. If you have both throat symptoms and bleeding while flossing, note both sets of symptoms and discuss them with your dentist and, if needed, your primary care clinician or an ENT. Medication review is part of the context check, not a directive to change therapy on your own. Many medications and supplements affect bleeding risk to varying degrees. Anticoagulant and antiplatelet agents increase bleeding tendencies. Certain herbal supplements and high-dose omega-3s may have mild effects, and some chemotherapeutic or immunomodulatory drugs can alter gum health. If you are on blood thinners, do not stop them with physician guidance. Instead, document their use and bring this information to your dental appointment. The treating team will coordinate as needed. As you complete the 48-hour period, keep the record you started. If you see clear improvement, keep the routine going. If you do not see improvement, or if any red flags appear, it's time to prioritize an appointment rather than extending home trials. Red flags that merit more urgent attention include heavy bleeding that's hard to control, pus or swelling that increases, new or worsening tooth mobility, systemic symptoms like fever or unexplained weight loss, or any sign of impaired breathing or swallowing. If any of those occur, seek prompt evaluation. The cause may be dental, ENT, or systemic, and timely diagnosis is important. At the end of the focus trial, you'll be at a decision point. Either the bleeding quiets down and you continue improved self-care plus routine dental follow-up, or bleeding persists and you need a closer professional look. The next step in care depends on the pattern you've observed. If the bleeding has improved but you have been inconsistent with dental visits, scheduling a professional prophylaxis, routine cleaning, is reasonable within the next few weeks to remove any residual calculus and reinforce oral hygiene. If bleeding persists, or you note additional worrying signs, a periodontal evaluation, including probing depths and radiographic assessment, becomes the priority. This is where the story typically splits into 3 common paths, and where a targeted, guided clinical conversation matters most. One path leads to reassurance and a renewed home routine. Another leads to focused dental treatment, such as scaling and root planing or restorative adjustments. And the third involves interdisciplinary investigation when systemic or ENT contributors are suspected. Each path has different timelines and implications. The first resolves over days to weeks. The second often requires weeks to months of periodontal therapy with staged reevaluations. And the third may entail laboratory tests, medication review, or ENT procedures to address contributing factors. Before moving on to those next steps in detail, there's one more practical piece worth covering while you're still in the home setting: how to prepare for a dental visit if that becomes necessary. Bring your bleeding log, list any medications and supplements, and note the specific teeth or areas that bleed. If you have photos of the visible area taken with good light, they can be helpful. Be prepared to describe onset and duration, and whether you have other symptoms, such as loose teeth, bad breath that hasn't improved with hygiene, or systemic signs like fatigue or increased thirst. These clues help your dentist or hygienist triage efficiently and decide whether to proceed with periodontal probing, radiographs, or referral. Now, suppose you finish the 48-hour trial and the bleeding has not budged. That result is not a failure of your effort. It is a clinically useful signal that the source likely extends beneath the gum margin or is driven by an external factor that requires hands-on assessment. In that situation, the dentist's initial exam will focus on several targeted assessments: pocket probing to measure attachment levels, visual and radiographic evaluation for bone loss, inspection of restorations and appliances for overhangs or rough margins, and a careful review of medical history and medications.
If probing shows pockets deeper than what is expected for healthy tissue, or if radiographs reveal bone loss, periodontal therapy will often be recommended. If pockets are shallow but a single contact shows persistent bleeding, restorative refinement may be the answer. There is also a middle scenario worth mentioning: bleeding that initially reduces with improved technique, but then plateaus at a low level.
That can be frustrating because it begs the question of whether more aggressive home care will resolve the last 10–20%, or whether there is a lingering local factor like calculus that only a clinician can remove. In these cases, a timely prophylaxis and focused hygiene counseling typically reset the situation and allow full recovery. At this juncture, you might be wondering about antiseptics, short-term rinses, or prescription products. Evidence supports short-term use of some antiseptic mouthwashes to help control gingival inflammation in the immediate post-procedural period or when mechanical cleaning is temporarily inadequate. However, routine long-term use of antiseptics without clinical oversight can cause taste disturbances, staining, or disruption of normal oral flora. If your clinician recommends a medicated rinse, follow their instructions and use it for the time they specify. We're approaching a crucial transition. You've done the quick checks, you've completed the 48-hour trial, and you have a clearer sense of where your problem might lie. If things have improved markedly, continue the new routine and schedule routine dental care. If bleeding persists, increases, or is accompanied by red flags, the next steps are a formal periodontal assessment and possibly radiographs or referrals to ENT or your primary care clinician for systemic evaluation. How your dental team approaches those next steps depends on the clinical findings, pocket depths, mobility, radiographic bone loss, and the presence of local irritants, and on your overall medical context. What follows are the clinical pathways and scripts to use during those appointments, and a detailed 2-week plan to bridge the gap between quick home fixes and definitive professional care. But before we go there, take a moment, review your log, note any changes in bleeding score, and be honest about your hygiene consistency. Small, sustainable improvements in daily care are often the difference between a brief episode of gingivitis and a longer course of periodontal treatment. If you're ready, we'll next walk through what your dentist will look for when you arrive, how to communicate your symptoms efficiently, and what realistic timelines to expect for recovery depending on the diagnosis. When you leave the home trial behind and walk into the dental office with your log, a few things will happen in a predictable order, because the exam is designed to turn the clues you collected at home into an actionable diagnosis. The clinician's first objective is to identify whether the bleeding you noticed on flossing is primarily a surface problem that resolves with improved hygiene, a deeper periodontal infection that needs professional therapy, a restorative or appliance-related irritant, or a clue to a medical condition that requires coordination with your primary care team. Knowing that helps set expectations for treatment timelines and next steps.
A typical initial dental exam for bleeding gums starts with a focused interview. The dentist or hygienist will ask about onset, pattern, and what you recorded in your log. Bring that log and any photos you took. They speed up triage and reduce recall bias. Expect questions about medications and supplements, smoking, recent illnesses or weight change, and whether you felt loose teeth or noticed nighttime clenching. Mention any ENT symptoms you noted, persistent postnasal drip, tonsil debris, chronic sore throat, because those details help rule in or out an oropharyngeal contributor. Next comes a clinical charting focused on the periodontal exam. The clinician will gently measure pocket depths around selected teeth or around every tooth, depending on the practice. These pocket measurements are key. Shallow measurements paired with mild redness usually indicate gingivitis, while pockets deeper than what is expected for healthy tissue suggest loss of attachment and a need for more extensive therapy. The clinician also checks for bleeding on probing, recession, mobility, furcation involvement, where multi-rooted teeth show bone loss between roots, and signs of local irritants like overhanging fillings or loose margins on crowns. Radiographs are commonly obtained. Bite wings are standard for assessing interproximal bone levels between back teeth, and periopacal or a full mouth series may be used if periodontal disease is suspected, or if individual tooth problems need closer evaluation. These imaging studies help determine whether bone loss is present and where it is located. If the findings are consistent with plaque-induced gingivitis, generalized redness and bleeding but shallow pockets, and no radiographic bone loss, the usual plan is straightforward. A professional prophylaxis, routine cleaning, to remove calculus and plaque above the gum line, paired with tailored home care instruction. You should expect meaningful clinical improvement within days to a few weeks after this conservative care if you maintain consistent, gentle interdental cleaning. If the exam shows deeper pockets, measurable attachment loss, and radiographic bone loss, the conversation shifts toward periodontal therapy. This is not a single dramatic procedure, but a staged process. Initial scaling and route planning, sometimes across multiple appointments, reevaluation after a few weeks to months, and then either continued non-surgical periodontal maintenance or referral to a periodontist for more advanced therapy.
Typical timelines look like this. Initial therapeutic phase over several visits within a few weeks, then a reassessment at about 4 to 12 weeks to see how tissues have responded. Longer-term monitoring and maintenance occur on a schedule determined by disease severity, often every 3 months for those with a history of periodontitis. These intervals are common practice, but individualized to your situation. Restorative problems get a different but parallel pathway.
If an overhanging margin, a poorly contoured crown, or a food trap is the suspect, your dentist may adjust or remake the restoration. Sometimes a localized area of bleeding requires only minor chairside correction or replacement of a filling. Other times, the restoration hides subgingival calculus that needs periodontal access for proper cleaning. The key point is that when bleeding is focal and linked to a single contact or tooth, mechanical or restorative factors are frequently involved. Interdisciplinary cases, where ENT or systemic issues contribute, are handled collaboratively. If you have chronic tonsil debris or persistent postnasal drip, and also notice bad breath or throat odor, your dentist may suggest an ENT consult to evaluate the oropharynx. An ENT may identify tonsilliths or significant postnasal drainage that contributes to odor, but generally not to interdental bleeding. Still, coexisting throat pathology can complicate the clinical picture and the patient's perception of symptoms. If systemic clues are present, unexplained weight loss, excessive thirst with polyuria, possible diabetes, unusual bruising, or a history of bleeding disorders, your dental team will advise seeing your primary care clinician so appropriate blood tests, glucose HbA1c, CBC, coagulation studies can be performed. These tests are diagnostic tools your PCP manages. They also guide dental planning when bleeding risk is increased. To make this practical, here are short, clinician-style phrases you can use at your appointment to describe what you found and to ask the right questions. Use them as templates when you speak with your dentist, periodontist, ENT, or primary care clinician. If you're speaking to your dentist or hygienist, I did a short home trial for bleeding gums. I tracked bleeding scores twice daily and noticed it occurs mostly along specified quadrant or teeth. I tried gentle interdental cleaning for 48 hours with saline rinses, but bleeding hasn't decreased. I'm bringing my log. Could you check pocket depths, look at my restorations, and recommend next steps? That frames the visit with objective data and asks for the core clinical assessments, probing, radiographs, and a restorative review. If you need to see a periodontist, my general dentist measured pockets up to, mentioned depth if reported, and radiographs showed, describe bone loss phrase if given, example, localized bone loss on lower left. I've been bleeding on floss for more than 2 weeks despite careful home care. What are the treatment options and expected timelines for improvement and maintenance? This invites a focused periodontal plan and a timeline for reevaluation. If you see an ENT, I have chronic postnasal drip and occasional white debris at the back of my throat. My dentist thought my breath might be related to tonsil crypts. Could you assess whether tonsillar disease or postnasal drainage is contributing to my symptoms?
That directs the ENT to the likely issues without implying they're the source of interdental bleeding. If speaking with your PCP about systemic concerns, I've been having persistent gum bleeding with flossing and some other symptoms like increased thirst, frequent urination, unexplained weight loss, persistent fatigue, or easy bruising. Could you check blood glucose, CBC, and coagulation studies as indicated? This requests appropriate screening tests and acknowledges that dental bleeding can have systemic contributors. A few patient vignettes illustrate how these pathways play out in real life. Anna, whose bleeding was focal after intermittent flossing, followed the 48-hour routine, saw improvement, and scheduled the routine cleaning. At her dental visit, the hygienist removed a small area of calculus and recommended a minor adjustment to an old filling that was trapping food. After a prophylaxis and a brief period of consistent interdental cleaning, her bleeding resolved. Marcus, who had generalized bleeding and mobility plus diabetes, followed a different path. His hygienist recorded deep pocket measurements in multiple quadrants, and radiographs revealed bone loss consistent with periodontitis. He underwent staged, non-surgical periodontal therapy with careful monitoring of his blood glucose in coordination with his PCP. Over several months, he completed initial therapy and entered a 3-month maintenance recall schedule to manage recurrence risk. Marcus also received counseling on smoking cessation and glycemic control, both of which materially improve periodontal outcomes. A third example, David, was on an anticoagulant for atrial fibrillation and noticed heavier bleeding than before. He did the home checks, documented persistent bleeding, and brought his medication list to the dentist. The dental team did not advise stopping the anticoagulant. Instead, they coordinated with David's cardiologist to confirm therapeutic ranges and planned conservative in-office care with appropriate hemostatic measures and monitoring. David's situation underscores the principle: document medications and coordinate care rather than change prescriptions on your own. Patients often ask what to expect from periodontal treatment in terms of feeling better. Here's a realistic set of expectations. With gingivitis, tissue color and bleeding often improve within days to a couple of weeks of consistent home care plus a professional cleaning. Pain is usually minimal. With periodontitis, initial therapy aims to reduce bacterial load and inflammation. Some bleeding and sensitivity may persist during the treatment phase, but pockets often shrink with repeated care and healing. Complete resolution of deep disease takes weeks to months and requires ongoing maintenance.
Surgical interventions, when indicated, are reserved for specific cases and are followed by a defined healing period. These are determined by the periodontist after non-surgical measures have been tried. People also ask about antiseptic rinses and short-term measures during the professional phase. Clinicians sometimes prescribe a medicated rinse for short durations when inflammation is significant or in the immediate postoperative period after periodontal therapy. These agents can be helpful as adjuncts, but are not substitutes for mechanical cleaning. If a medicated rinse is recommended, use it only as directed to minimize side effects like taste alteration or staining. A common question is, how long should I wait before I expect a definitive answer from my dentist? After an initial periodontal therapy phase, many clinicians schedule a reevaluation at 4 to 12 weeks. That window allows soft tissues to heal and for measurable changes in pocket depths to become apparent. If the tissues respond well, the clinician will move you into a maintenance program. If pockets remain deep or disease is active, more advanced therapy or referral to a specialist may follow. The reevaluation period is not arbitrary. It is a clinically useful interval for assessing tissue response. Insurance and cost considerations sometimes affect timing. Routine prophylaxis and initial periodontal therapy are commonly covered to varying degrees by dental insurance, but coverage details differ. Don't let cost concerns delay urgent care if red flags are present. Discuss phased care and payment options with your dental office. Many practices offer financing or phased treatment plans that prioritize urgent needs first. Maintenance is a word that deserves emphasis because periodontitis is a chronic disease in many adults. Management, rather than a one-off cure, is often the realistic goal. After initial therapy, patients with a history of periodontitis typically move to a maintenance program that includes professional cleaning at intervals determined by disease severity, usually every 3 months for high-risk individuals, and sometimes longer for those at lower risk. During maintenance visits, clinicians remove any new calculus, reinforce home care, and reassess pocket depths in bleeding. This cadence is a preventive tool to keep disease from recurring. Risk reduction strategies go hand in hand with treatment. Smoking cessation has one of the largest impacts on periodontal health. Tobacco reduces healing responses and increases disease severity. Good glycemic control in diabetes markedly improves periodontal outcomes. If you have diabetes, coordinate with your PCP to optimize control. Stress, poor sleep, and dietary patterns that favor a high-sugar environment can also influence oral microbial communities, so a holistic approach helps.
Appliance hygiene. Keeping removable prostheses, orthodontic appliances, and night guards clean prevents plaque accumulation that can irritate adjacent gums. Some viewers worry that antiseptic mouthwashes or aggressive at-home rinses could replace professional care. They cannot. Mechanical removal of plaque by brush, floss, or interdental brushes is the cornerstone of prevention. Chemical adjuncts can support but not replace that mechanical action. Also, prolonged unsupervised use of strong antiseptics can carry side effects. If your clinician prescribes a rinse, follow their duration and frequency guidance. Now, a practical 2-week plan that builds on your 48-hour trial and bridges the gap to a clinical appointment if one is needed. Continue the gentle interdental routine you used in the trial. Once daily thorough interdental cleaning, plus light interdental cleaning at each major brushing if possible. Rinse with warm salt water at night to soothe inflamed areas. Maintain hydration and saliva stimulation with sugar-free gum when appropriate. Replace your manual toothbrush or change the electric toothbrush head if it's older than 3 months or shows frayed bristles. Clean any appliances thoroughly. Keep your bleeding log for the entire 2 weeks. Documenting trends helps the clinician decide whether earlier intervention is necessary. During this 2-week period, watch for changes that alter the plan. If bleeding diminishes steadily, maintain the new routine and schedule a routine dental cleaning within a few weeks if you are due. If bleeding persists beyond 2 weeks without improvement, or if other concerning signs appear, joint mobility, increasing recession, persistent swelling or pus, severe pain, fever, or systemic symptoms, prioritize an appointment promptly rather than extending home care. If you're in doubt, call your dental office and describe the trend. Many practices can advise whether an expedited visit is needed. To make clinical visits more efficient, here are short script ideas for how to present your concern and your expectations. When checking in at the dental office, I did a 2-day home trial and continued a full 2-week plan. My bleeding score has described trend, and I noticed list any mobility, pus, or systemic symptoms. I would like an exam and radiographs to evaluate periodontal status and any restorative contributors. When asking about likely timelines,
Based on today's findings, how long until I should expect a measurable reduction in bleeding with your recommended plan? When will you reevaluate healing? When discussing referrals, do you recommend referral to a periodontist or ENT? And if so, what specifically would you like them to assess? When needing coordination with your primary care clinician, my dentist suggested my bleeding could be influenced by systemic factors and recommended a glucose check and a CBC. Could you run those tests and advise if anything should change regarding my medications?
A brief, clear paragraph for each specialty, dentist, periodontist, ENT, PCP, can also be used by reception staff to triage the urgency of referrals. For example, when your dentist refers you to a periodontist, a succinct referral note that includes pocket depths, radiographic findings, bleeding pattern, and the logs you kept will make the specialist visit faster and more productive. A focused section on red flags and urgent signs is important. Seek prompt care if you experience heavy bleeding that's hard to control despite gentle pressure, rapidly increasing facial swelling, severe tooth pain with fever, rapidly worsening tooth mobility, any sign of infection spreading, increasing redness and warmth beyond the tooth area, difficulty breathing or swallowing, or any systemic signs like high fever, unexplained weight loss, or extreme fatigue. Those signs may reflect an acute dental abscess, spreading infection, or a systemic condition that needs urgent assessment. Some final practical tips clinicians often share that help maintain gains and reduce recurrence risk. Schedule regular dentistry even when things feel stable. Use interdental cleaning devices that fit your anatomy, interdental brushes for wider spaces, floss for tight contacts. Get restorative issues addressed promptly to avoid chronic irritation, and coordinate with your medical providers about conditions like diabetes or medications that affect bleeding. Keep the conversation open. If something changes, call rather than waiting. Before we close, here are concise sample clinician scripts you can use, tailored to each specialty and designed to be short enough to read aloud at the appointment. For the general dentist or hygienist, I did a structured home trial and brought a bleeding log. I noticed bleeding primarily at specified sites, and saline rinses and improved technique for 48 hours didn't fully resolve it. Please assess pocket depths, check restorations and appliances, and take radiographs as needed. I'd like to know whether this is gingivitis manageable with a prophylaxis or whether I should plan for periodontal therapy. For the periodontist, referral for evaluation of persistent interdental bleeding despite conservative home care. Pocket depths measured up to value with radiographic evidence of described bone loss if known. Please advise on non-surgical versus surgical management, reevaluation intervals, and expected maintenance schedule. For the ENT, patient reports chronic postnasal drainage and intermittent tonsillar debris in addition to dental bleeding. Please evaluate for tonsillithoth, cryptic tonsils, or chronic upper airway drainage that could contribute to halitosis or complicate oral hygiene. For the primary care clinician, patient has persistent gum bleeding despite a 2-week home care plan.
Please evaluate for systemic contributors. Obtain CBC, HbA1c, or glucose testing and coagulation studies if clinically indicated, and advise on medication interactions that may affect bleeding risk. As you prepare to leave the office after an evaluation, you should have a clear plan, either a conservative follow-up with routine cleaning and home care reinforcement, a staged periodontal treatment plan with specific reevaluation dates, restorative corrections scheduled, or referrals to appropriate specialists. Ask for a written summary or a copy of any charting and radiographs. These are useful for follow-ups or second opinions. To summarize, in practical action steps for what to do after watching this video, continue gentle, consistent interdental cleaning. Maintain a bleeding log for objective tracking. Use saline rinses and hydration to support healing. Avoid aggressive self-interventions. And if bleeding persists beyond the 2-week window, or if any red flags arise, schedule a dental appointment promptly with the information you recorded. Bring your medication list, bleeding log, and any photos to that visit to help the clinician triage quickly. Bleeding gums when flossing is common and usually manageable, but because it is a signal, not a verdict, it deserves a measured response that starts at home and progresses to professional care if necessary. Many cases will quiet down with improved technique and a single professional cleaning. Others will require targeted periodontal or restorative care. A smaller number reflect systemic issues that demand coordinated medical evaluation. The deliberate approach you've learned, a set of quick checks, a 48-hour trial, a 2-week plan, and clear thresholds for professional referral, gives you evidence-framed steps to follow without panic and with safety in mind. If you've been tracking bleeding and it hasn't improved, or if you notice any of the red flags discussed, schedule that dental visit and bring your notes. Getting a professional periodontal evaluation sooner rather than later when problems persist typically leads to simpler and more predictable care. If you found this guidance helpful, consider sharing it with someone who's been hesitant to bring up bleeding gums at their next dental visit. Helping someone prioritize care can prevent longer-term problems. If bleeding persists beyond your trial or you have any urgent signs, make an appointment with your dentist or periodontist today.